What's up, Ninja Nerds? In this video today, we're going to be talking about liver function tests. That's also known as LFTs. Again, this is a part of our clinical medicine section, and I really hope that you guys are liking these videos. I really hope they're making sense and they're really helping you to understand the topic really well. And if they do, please support us. And some of the simple ways that you can do that is by hitting the like button and commenting down the comment section and subscribing. It really goes a long way. Also, I really truly believe this. If you guys go down the description box below, click on the link that goes to our website, become a member, there's going to be many benefits to you that'll help you to understand these topics even better. Things that we have: notes, really good notes, illustrations, quiz questions, and we're even developing exam prep courses. So go check that out and really gain some understanding of these topics and master these topics. All right, let's talk about LFTs. So, liver function test is a really interesting term, and sometimes I think it's a misnomer because when you look at LFTs in the sense that you're trying to determine liver function, it is really good. It can give you a kind of a basic concept of basic hepatic function. But also it's a misnomer because it also gives us a concept of liver injury. And so when we talk about liver function tests, I like to really call them like liver biochemical tests because it tells us about hepatic function and hepatobiliary injury. So let's get a basic kind of introduction, some small pathophys, and then we're going to go into some of these in more detail. First thing is when we talk about a patient who comes in, maybe they're coming in jaundiced, so they have a yellowish discoloration. Maybe they're coming in with right upper quadrant abdominal pain, which we think that could be a hepatobiliary injury. Maybe they're coming in with fulminant encephalopathy. In these particular scenarios, it's really good to have an understanding of, hey, I should probably send off some LFTs for these patients and look to see, do they have anything going on? If you send off those LFTs, there's three things that you want to be able to keep in your mind as you're working these patients up. The first one, is there evidence of hepatocellular injury? Oftentimes, the way that we determine hepatocellular injury is, if I take this basic diagram here, here's our hepatocyte. All right, so here's the first part. Here's the hepatocyte. This is just one component of the liver. I'm looking at a bunch of these little hepatocytes here. The next thing is we have an artery. This is just representing the hepatic artery that supplies oxygenated blood to what? To the hepatocytes. So here, I'm going to do this one in red here. This is our hepatic artery right here. Okay, now the other concept is that this one gives oxygenated blood. This one removes any kind of particular deoxygenated blood and blood that's rich in relative nutrients that have been cleansed and cleansed of any toxins. And so we call this one the hepatic vein. And this is going to be removing blood from the liver and going to put that blood into the inferior vena cava. This one is going to be called the portal vein. This one is taking a bunch of different blood from the GIT and from other organs associated or accessory to the actual GIT and taking it to the liver, rich in nutrients, rich in toxins. It's going to be cleansed. And then the last one here is you have your bile duct or the bile canaliculi. And this is really important because it actually helps to take things like bile, which is rich in bile salts and bilirubin and cholesterol, and take that down into the gut as we see here. Okay? So these are the different components of our basic diagram. We're going to use this a lot. The concept I want you guys to understand is if there's injury to these hepatocytes, they're damaged. There's many different ways that we can damage these hepatocytes. And when they are damaged, one of the things that happens here is that they start to leak specific molecules or enzymes that are present inside of these cells. And those molecules that are usually sitting here are going to be primarily AST and ALT. There is going to be other molecules in here such as bilirubin, but this is going to be the primary molecules that are indicative of direct injury or indirect injury to the hepatocytes. So whenever a patient gets these labs done, the LFTs, and we see a marked elevation in the AST and the ALT, this really tells me there's an injury to the hepatocyte. And we'll talk about some of the reasons the hepatocytes get injured. They could be directly from drugs and toxins, etc. It could be from hepatic artery damage. It could be from hepatic vein damage, or it can be from biliary duct obstruction. And we'll talk about those in more detail. But if I see a massively elevated AST, ALT, I'm thinking hepatocellular injury, and we'll go through the differentials in the next topic. If a patient then gets evaluated, they're coming in, again, jaundice, right upper quadrant abdominal pain, maybe encephalopathic, etc. Then we should also get LFTs and again evaluate, is there another thing that's going on? So same thing here, hepatocyte, bile duct, small intestine, some bloodstream, all right? So what happens here is, let's say that this patient has a problem. And the particular problem here with cholestasis is there is a decreased movement of bile through the biliary system into the small intestine. And there's two ways that this usually happens, and we'll go into this in great detail. One is we call this intrahepatic cholestasis. And with intrahepatic cholestasis, this means that there is not really a good movement of bile, usually with inside of the liver. So here's our hepatocytes, here the biliary canaliculi within the or surrounding the hepatocytes. Usually what happens is these hepatocytes make bile, and they secrete this bile into the biliary system. And then it's supposed to move through the biliary system and then from here into the small intestine to help it aid in digestion. What happens here is that in these patients, they don't excrete this bile. And when they don't excrete this bile, it builds up in the hepatocytes. And then the hepatocytes become agitated with that. They become really affected by that. And then what happens is these hepatocytes and biliary cells start secreting a couple different chemicals, and they accumulate in a large amount. And then what happens is some of these chemicals will back up into the actual circulatory system. And these two chemicals that really are indicative of cholestasis is alkaline phosphate. Another one that we referred to here is what's called GGT. And then the last one that's really also indicative of cholestasis is bilirubin. And that's one of the components of the bile. So again, the concept behind having these elevations is that when the hepatocytes have difficulty excreting the bile builds up inside of these hepatocytes. Or if there's injury to the biliary duct cells, whenever there's injury to these cells, they respond by increasing the expression of alkaline phosphatate. And bilirubin builds up in these cells and then moves into the bloodstream. And so when I see patients who have elevated bilirubin and elevated alkaline phosphatate or GGT, it really makes me think, is there something going on in the liver cell? Or is there something outside of the liver that's obstructing the flow of bile and then it backs up into the bloodstream? And this would be what we call extrahepatic cholestasis. And we'll go into some of the actual differentials associated with this one as well. All right, so two things I want you guys to think about whenever you see a patient who has elevated bilirubin, alk phos, GGT, is think, is there intrahepatic cholestasis, something where I'm not secreting bile building up, or I'm injuring the biliary duct cells and causing them to increase the expression of alk phos and GGT, and as a result, they build up in the bloodstream, and then bile from the actual hepatocytes leaks into the actual bloodstream, so you get increased bilirubin, alk phos, or GGT, or is there an obstruction that's impairing the flow of bile, and that's backing up into the blood? The last concept that I want you guys to understand here is if we work a patient up and they don't show marked elevation AST, ALT, they don't show marked elevation in the alk phos, the GGT, and the bilirubin, they only show maybe a combination of a bunch of things. And one of the things that we really want to understand is hyperbilirubinemia. This is really kind of the temperature, the thermostat of what really liver function and liver injury looks like. So there's a couple different ways that bilirubin is kind of like moving through the actual bloodstream in the liver, and it's really important to understand it. Well, the basic idea here. Here, we have like a macrophage, and a macrophage is going to be one of the main cells that eats up red blood cells. When it eats up red blood cells, it secretes that molecule into the bloodstream, and it's called bilirubin. And I'm going to put next to this bilirubin, I'm going to put what we call, so there's two different types of bilirubin. One, we call it unconjugated, meaning it's not bound to glucuronate, or it is conjugated, it's bound to glucuronate. This one is not. So it's called unconjugated or indirect bili. So I'm going to put I-bili, which is just a fancy way of saying this is unconjugated bilirubin. This is released from the macrophages. From the macrophages, it gets to the hepatocytes. It gets taken into the hepatocytes. From here, there's an enzyme. It's called UGT, and uridine glucuronosyl transferase enzyme, and it puts a glucuronate on. When it puts the glucuronate on, it's now converted into conjugated bilirubin, which we're going to call, so this is bilirubin, but it's a specialized bilirubin that we call direct bilirubin, or D-bili. It's a fancy word for conjugated bilirubin. Then that D-bili is then going to be moved via transporter into the bile system, and then from the bile system they'll come out into the small intestine where they'll aid digestion. A couple different things will happen in this process that you have to be able to understand. When patients have diseases, we want to be able to understand which is the type of bilirubin that is elevated, because you can have an elevation in both of these or one of them. So there's 3 different types that we will discuss here. One is if the bloodstream has elevated levels of indirect bilirubin, we call that unconjugated hyperbilirubinemia. So I want to know, do they have unconjugated? And I'm going to put bili, and I'll put an up arrow to indicate that they have elevated levels of unconjugated bilirubin. Do they have mixed? Do they have a decent degree of mixed bili? So in other words, they have elevated both unconjugated and unconjugated. And then lastly, is it primarily elevation and only conjugated bili? And we'll talk about what this particularly, the differential is and what this can look like. Oftentimes for these patients, when you think about unconjugated, it has to happen from the macrophage to this point all the way until we get to this point. So any disease process has to occur above that enzyme or at the level of the enzyme. Anything from mixed can be a combination of disease that's occurring anywhere from here all the way to here, and then conjugated is it's only occurring from this point after the UGT down to the small intestine. So we'll talk about all those differentials. But oftentimes the primary thing is that these patients will present with an elevated bilirubin. They can also present, and that's what's going to help us here, they can also present, depending upon the type that they have, they may present with a plus or minus, we'll put here, plus or minus an elevated AST, ALT, or alk-phos. But the actual thing that you need to understand is it depends upon which type. And we'll go into that. Oftentimes, if you don't see any of these elevated and you just see unconjugated bili, it's hemolysis. And we'll go over each one of these. I don't want to get too far ahead because we'll discuss these in detail. But that's the big thing to think about. Does the patient have elevated AST, ALT? It's hepatocellular primarily. Do they have an increase in the alkaline phosphatase GGT with bili? It's cholestasis. Do they have an increase in bili? And that's the primary one that we're trying to think of. If you want to know which type of bilirubin is elevated, and that'll help us to think about the differential. All right, this is the concept of hepatocellular injury. What about the test that we use for hepatic function? We don't have great tests for hepatic function. We're better at being able to determine tests for hepatobiliary injury, but there is some tests that we can utilize here. One of the tests that we utilize for hepatic function is that the liver produces a particular molecule here, and this molecule is called albumin. And albumin is a plasma protein, and what it helps to do is it helps to be able to regulate the oncotic or osmotic pressure in blood vessels. So if you have, let's say, a disease, and we'll talk about 2 particular diseases here. One is you have a disease called cirrhosis, which is like a chronic liver disease. It's like a slow kind of like simmering liver dysfunction over many years. Or you have an acute abrupt onset of decreased hepatic function in the scenario of acute liver failure. You may really see a lot of this decrease in hepatic function become super obvious. So one of the things is that your albumin levels will drop. If albumin drops, then we don't maintain as much of this osmotic or oncotic pressure in the bloodstream. So this is going to be impaired. There's a decrease in the osmotic pressure. If there's a decrease in the osmotic pressure as an effect of this, so we'll put here on the side, a decrease in osmotic or oncotic pressure, it's the same dang thing. The process here is that fluid is going to leak. So it's going to cause capillary leakage. And whenever fluid leaks out of the capillaries, it leaks into particular types of interstitial spaces or cavities. So what are some of these? Well, one is it'll leak into the pleura, and it'll leak into the actual peritoneum. And so they'll develop Potentially, what's this called whenever you have lots of fluid building up in the actual peritoneum? Ascites. What's it called when you have fluid building up within the pleural cavity? Pleural effusions. So oftentimes these patients can develop what we call pleural effusions, and they can also develop something called ascites. So watch out for a patient who has decent amounts of pleural effusions as a result of the significantly decreased albumin, as well as watch out for ascites. And this would be an ascites that has a sag that's usually less than 1.1 because it's more of an exudative type. The other thing is that fluid can leak into the interstitial spaces in the legs. And these patients can also develop some pretty good edema. So look for any kind of like generalized pedal or pitting type of edema. So we'll put pitting edema. This is a big thing to watch out for. All right, so that's one of the big things to watch out for with albumin, is a lot of more edematous types of appearances. The other thing that we really use to kind of give us an idea of hepatic function is that the liver also produces a lot of what's called anticoagulants and procoagulants. So it'll produce a bunch of different molecules here. And if in this scenario we don't produce albumin because the liver is dysfunctional, right? So it's damaged because of acute or chronic liver disease. So acute is usually just a profound hepatocellular injury or a profound types of damage to the liver without ability to compensate and regenerate, where cirrhosis, it's repeated injury with fibrosis and nodular degeneration. Either way, we're not going to produce these clotting proteins. What are some of these clotting proteins that are oftentimes produced by the liver in normal, healthy individuals? Well, there's what we call factor 2, factor 7, which is a really big one, factor 9, factor 10, and then another 2, which are 3 technically if you want to think about these other ones. We call this one antithrombin 3, which is this guy, and then protein C and protein S. So there's lots of these. But the big ones that I think are really, really important here are going to be these ones right here, because these are what we call procoagulants. These are what we call anticoagulants. In liver disease, where you lose the ability to produce these things, you're going to have a decreased number of these and a decreased number of these. But if something happens to these patients that tips them out of this abnormality, they can definitely have less of these, especially the procoagulants. And this is the problem. When you have less procoagulants, these are things that wants to induce clots, what do you think is going to happen? These patients will now not be able to form clots. So they have an increased risk of bleeding. So they're going to have an increased risk of bleeding or some type of disease that we call where there's inappropriate ability to form proper clots, or in that scenario, what do we call that? We call that coagulopathy. And the ways that we look at this is 2 particular ways. One is that if you have a decrease in the procoagulants, we see this potential process, bleeding. And we'll talk about what that particularly looks like. But the other concept here is when you have less of these procoagulants, it alters a particular lab value. And one of the particular lab values that's really dependent upon factor 7 is called the PT-INR. And what we will notice in patients with really profound liver failure is that their PT-INR will start to go up, at least to greater than 1.5. And that's usually indicative that they're not able to properly clot. So that's another way that we can look for this type of profound decrease in hepatic function. Or we can look at it clinically, where they develop bleeds in the brain, ICHs. They develop bleeds from the nose or from the mouth, or on the skin like petechial lesions, so mucocutaneous bleedings, or intracranial hemorrhages, or they bleed from the GIT, such as hematemesis, or maybe a lower GI bleed. These are big things to think about. And something else that actually worsens that coagulopathy and increases the risk of bleeding is the liver also produces a hormone called TPO. We call this thrombopoietin. And when thrombopoietin is not able to be produced, it's supposed to tell the bone marrow to make platelets. You won't make the platelets. What is that called when you have decreasing number of platelets? Thrombocytopenia. So these patients can have what's called thrombocytopenia relatively chronically, and that definitely propagates the risk of coagulopathy. It won't affect the INR, but it will cause them to be a little bit more coagulopathic. The last thing, we'll talk about this more in acute liver failure and cirrhosis. We just don't have tests for these that are really, really great. One thing that we can also look at to a certain degree is that these patients may lose the ability to clear ammonia. And so ammonia levels may be potentially elevated in patients with underlying hepatic dysfunction. And the other thing is that bilirubin is a marker of liver injury, but it's also a marker of liver function. That's weird, right? It can be a measure of both. And so when patients also have an inability to conjugate bilirubin and excrete bilirubin, they may potentially have an increase in bili that's maybe not even related to the liver injury itself. It could just be related to the inability to conjugate or excrete bilirubin. And these are also different tests, but oftentimes the big ways that we kind of do this on the exam is by looking at PT-INR, risk of coagulopathy, and low albumin. There used to be other tests that we would do with these, such as looking at ammonia, looking at bilirubin levels with certain types of weird things, but we don't often do that anymore because they're kind of scary. They used to do things like check the bilirubin levels after you give a patient rifampin if they have liver disease, or there used to be one lady who used to say, let's give ammonia to people, and if they have good liver function, they'll clear it. If they don't, they won't clear the ammonia and they'll develop encephalopathy. We can't do that to patients, that's not ethical, so we don't really do those things anymore. But that gives us an idea now of how we should look at these tests. The big ones that are really going to be tested on your exams is going to be this one. So we're going to go into each one of these into great detail. Let's do that now. All right, my friends. So now a patient comes in, they get their LFTs done. When you get the LFTs back, you see, oh, their AST and their ALT is really elevated. I think it's important to have an understanding of, is this an acute enzyme elevation? Is it a chronic enzyme elevation? So does it look like, if you have a comparison to their prior LFTs, what does it look like? Does it look like it's about what it's usually at? Or did it look like it really jumped up acutely into some pretty high numbers? And when I consider like an acute, like massive elevation, I'm looking for really at least greater than 1,000. So really to call this like an acute and significant elevation, I'm looking for levels that are greater than 1,000 of the AST and the ALT. And that's pretty significant. When I see acute and massive elevations in the LFTs, the AST and the ALT, there's a couple differentials that'll come to my mind that these are the only real things that can cause massive elevation. The first one is I like to think about drugs. So what we call a DILI. So a drug-induced liver injury. And there's really only one of these drugs that has been really commonly known to cause pretty significant hepatotoxicity if given in large amounts, at least way more than 4 grams per day. And that's usually Tylenol. So that's one thing, is I'm gonna look at the patient's history. Maybe I'll check a Tylenol level. And if they're really taking large amounts of Tylenol and their levels suggest that, that could really be indicative of a DILI that caused this greater than 1,000 bump. The other one that I think about is vascular. So vascular causes, which we'll go into pretty significantly, this is usually going to be a really big one. And I'd say out of the vascular causes, 2 are probably going to be the most significant, and that's usually arterial, and the other one would be like a Budd-Chiari syndrome. So vascular causes, and I'd say the biggest one out of all of these is going to be ischemic hepatitis, and we'll talk a little bit about that one a little bit later. The other one that really causes pretty significant elevations is viral. So usually viral infections are going to be a big one. And there's really a couple. I'd say hepatitis A is relatively rare. Hepatitis E, somewhat common, especially in pregnant patients. Hepatitis B virus, especially with co-infection of D, has been shown to be a pretty common one that can cause both acute and chronic. Another one is going to be autoimmune. So autoimmune disease can kind of like be a slowing Kettering one as well with chronic elevations, but if you get a pretty good autoimmune kind of attack, your patients can have pretty significant massive elevations in their enzymes. And the last one I really don't like to kind of avoid just because it really can cause these problems is when a patient develops an acute biliary obstruction, usually like a choledocholithiasis. These can really cause some specifically decent elevations in the AST and the ALT. So these are the things that I want you to think about. If a patient comes in and they definitely have increasing ASTs and ALTs, think, is it massive? If it is, you already have like a differential to go through, and we'll talk about these in a little bit more. If it's not that, and it's a little bit like lower, and I like to use like, usually maybe it's chronic or it's very small elevations, like less than 500, would really kind of make me think that it's not necessarily one of these things. The things I like to think about in this particular scenario could also be DILI. So this would usually be more particularly alcohol related. And we'll talk a little bit later because alcohol has really been linked to this like particular ratio. And one of the things that we often say a lot is that alcohol, that ratio is usually where the AST to ALT ratio is usually greater than 2. So the ratio there I think is helpful as long as it's in the lower numbers, less than 500. As you get up to the higher one, I don't really feel like this ratio consistently kind of works. But this is something to definitely think about on your boards exam. The other one would be metabolic causes, so metabolic diseases. I know that a lot of the time people will think that if a patient comes in and they have like these massive elevations that it could be Wilson's disease or hemochromatosis. As much as we want to will that into existence, I don't think that's the case. You'll be looking to write case reports. Oftentimes, Wilson's disease won't generally present as much acutely, and neither will hemochromatosis. And the other one that generally won't present with these massive ones is going to be non-alcoholic fatty liver disease. So those three particular ones I would really be thinking about in the non-alcoholic fatty liver disease patient. I would also be thinking about this in the Wilson's patient, and I would also be thinking about this in the hemochromatosis patient, okay? But these are the ones that I would definitely potentially consider if I'm looking for a metabolic disease. Obviously this one, obesity, hyperlipidemia, hypertension, other kinds of factors of metabolic syndrome. This one, Kaiser-Fleischer-Rings, CNS dysfunction. This one, hyperpigmentation, pancreatic dysfunction with diabetes, and restrictive cardiomyopathy are common. The other one that I think is really important is going to be like viruses, but it's oftentimes a very particular virus, and this is usually hepatitis C virus. Sometimes hepatitis B virus as well, but hepatitis C virus is really the big one that I want you to associate with more of that chronic types of liver disease. And then the last one is pretty common, and this is cirrhosis. Cirrhosis is obviously a very chronic dysfunction of the liver over time. So this is also because as you cause damage to the liver, as you impede more of the liver function by causing excessive fibrosis and nodular degeneration, you lose cells that have the capability of releasing AST and ALT. So levels will actually slowly drop to almost being normal over time, a pseudo-normalization. So let that help you to guide what your differential is right off the get-go. But then once you get these levels of an elevated AST and ALT, to develop a differential that it could either be direct parenchymal injury, vascular dysfunction, or finally, could it be a biliary obstruction? So the first thing is, what if it's a vascular dysfunction? There's a couple different things here. So here we have the hepatic artery. Remember I told you guys, remember this diagram? This one delivers oxygen-rich blood to what? To the liver. Well, what if there is a decreased delivery or no delivery of oxygen to these hepatocytes? That would be a problem. And then as a result, these cells will start becoming injured. As they get injured, they'll pump out what? Increasing amounts of AST and ALT. In this particular situation, we already kind of talked a little bit about this. This is a vascular cause. In vascular causes, such as arterial-related, this will cause massive elevations. This is usually what we refer to as ischemic hepatitis. And oftentimes, the most common cause of a patient developing ischemic hepatitis is going to be profound hypotension. So I really want you to look at this when a patient has really, really low blood pressure. And this could be seen in a couple different types of shocks. You can see this in cardiogenic shock, hypovolemic shock, septic shock. So look for a patient who is in overt shock. And this has caused decreased perfusion to the tissue, decreased oxygen delivery, and hepatocellular injury. So that'd be one type of vascular dysfunction. So that'd be the artery-related type. What if it's a venous-related disease? So the venous system is supposed to take blood from these hepatocytes, from the sinusoids, and eventually return this to the inferior vena cava. What if, though, in this scenario, there is an obstruction or high pressure, high back pressure that's impeding the outflow? This will lead to what we call venous congestion. And that venous congestion, if blood is not able to leave the liver, it causes higher liver pressures, higher sinusoidal pressures. And those pressures will definitely start leading to injury to the liver because it's not able to drain properly. There's a couple different things I want you to think about here. One is, what if the back pressure is really high? They have what's called an elevated central venous pressure. That would be in the scenario of what we call right heart failure. So look at the patient's echo. Look to see if they have a history of right heart failure. And the other one is a clot. And this is usually what we call Budd-Chiari syndrome. Usually you see this in a patient with hypercoagulability, you see this in a patient with malignancy, or you see this in a patient with polycythemia. But either way, blood is not getting out because there's a clot or there's high pressure that's preventing it from leaving. The next one is going to be parenchymal injury. All right, so this is a really, really big one. And this is where there is direct injury to the liver cell itself. And as you damage these liver cells, you'll see these pumping up levels of AST and ALT. There's many, many causes of these. We're going to need to write a couple of these down. So the first one, and I think by far the biggest thing that you want to be considering in a patient with massive elevations, is did they take any drugs? It's the first one that I think is really, really important. So did they pop any Tylenol pills in large amounts? All right, that's the first one. Or do they have a history of chronic alcohol use? There's a lot of different things that we can try to utilize to our advantage with this, with drug-induced. You can check a Tylenol level. If they're taking at least levels greater than 4 grams per day, this is definitely going to cause this type of problem. The other one is alcohol. Alcohol use, excessive alcohol use can cause elevated GGT levels, but also affect that ratio that we talked about, the AST to ALT ratio greater than 2. So think about elevated GGT, history of ethanol use, and think about the AST to ALT ratio. The other one that I think is really important that really causes this is metabolic diseases, all right? Especially more of the chronic, kind of like slow and Kettering elevation. And that types of causes, there's many of these. I don't want you to get too caught up about all of these. We talk about them a lot more in the inherited liver diseases, but this is going to be things like hemochromatosis. Oftentimes with this one, this will cause more of the slow, kind of like slow chronic elevation. Wilson's disease, slow chronic elevation. Alpha-1 antitrypsin deficiency, slow elevation. And the last one is non-alcoholic fatty liver disease. That'll cause a slow elevation. With metabolic diseases, the things that'll make you think about these is obviously they won't be massively elevated, but you're gonna have a bunch of different tests for these. We'll talk about them a lot more. But this one's related to elevated iron, elevated copper, decreasing levels of alpha-1, and this is usually associated with metabolic syndrome. So we'll write down each one of these. Think about elevated iron levels, elevated copper levels, and metabolic syndrome. In other words, the patient with obesity, kind of like slowly elevated glucose levels because of what we call insulin resistance, hypertension, dyslipidemia. There's one other thing. Oftentimes with a non-alcoholic fatty liver disease, what happens is their ratio also changes a little bit too. And so sometimes we'll see kind of an opposite. You'll flip the ratio with alcohol in comparison to non-alcoholic fatty liver disease. So you'll start seeing that their ALT in comparison to their AST will actually be flipped a little bit. And so that's an important one to remember. All right, so these are the big things to remember here. The last kind of thing that I want you guys to remember besides metabolic diseases is autoimmune. So autoimmune is this kind of like really interesting disease. It doesn't often cause like super obvious presentations that you would think. So in patients with autoimmune hepatitis, maybe you'll get lucky and they'll have some other autoimmune diseases. Maybe they'll have some joint diseases and other things like that. But oftentimes you won't see anything specific. And so oftentimes when a patient has a massive elevation in their enzymes, you think autoimmune, and you want to test for a couple different antibodies that have been linked to directly injuring the parenchyma. A couple of those are going to be ANA, anti-smooth muscle antibody, IgG, and if you feel a little extra, and more particularly in the younger patient population, you can even consider an anti-LKM1, liver kidney microsomal 1 antibody. But oftentimes these are the big things that at least this one is the highest yield one, the anti-smooth muscle antibody that you really want to think about. So these are things to think about in your differential. Drugs, metabolic diseases. Usually this will cause other features like pancreatic injury, so diabetes, restrictive cardiomyopathy. This one, Kaiser-Fleischer rings, CNS dysfunction. This one, emphysema. This one, usually you're seeing prominent features of obesity. The last concept is biliary obstruction. When a patient develops an acute biliary obstruction, usually the most common cause is they get a stone. And when you get a stone inside of these like biliary ducts, so here we have like a bile duct. And in this bile duct, there's a stone. That stone will cause a massive back pressure to kind of be exerted onto the liver. On top of that, things like bile will leak into these. And bile acids and bile salts love to cause direct injury to the hepatocytes. So there's a lot of oxidative stress there. And that'll cause these massive elevations in AST and ALT. The big thing to remember for this one is by far the most common cause for this is going to be choledocholithiasis. So I would really, really look for this one in a patient with choledocholithiasis. And then maybe a patient with really profound elevated levels with an infection appearing. So something like ascending cholangitis. So we call this ascending cholangitis. All right. One other thing with biliary obstruction that's really interesting, all of these that we talked about will cause massive elevations in AST and ALT, usually alone. With biliary obstruction, the big thing to remember is this one will also cause a marked, because it's a cholestasis effect. You'll get marked elevation in alkaline phosphate, GGT, and you'll get elevation in bilirubin within the bloodstream. You can get this with some of these other ones, but not to the same degree that you'll get with a biliary obstruction. So really think about that in the differential when you see massive elevations in alk phos, GGT, and bilirubin in a combination with elevations in AST and ALT. All right, now let's go into the diagnostic approach of this. So we have an idea now of the pathophysiology really of this. We kind of have the causes. We broke down a lot of these. And I think now we can generate a pretty good diagnostic approach. Elevation in AST, ALT, okay, I remember off the R value, if it's really elevated and I don't really have any significant elevation in my alk phos GGT, it's probably hepatocellular. I can say the R value would be, in this scenario, greater than 5. If it's hepatocellular, then I got to start thinking of the causes. If it's a DILI, then there's two types. Tylenol toxicity, so I'd have an elevated Tylenol level. And on top of that, with Tylenol toxicity, what kind of elevation do they have? Massive elevations, greater than 1,000. That would suggest the Tylenol toxicity. If it's like less than 500, it's not super high, and their AST to ALT ratio is greater than 2, that suggests more of that alcoholic liver disease patient. Vascular causes are always going to be pretty high. You're at least going to have them greater than 500, maybe even greater than 1,000. Because of that, again, think about the scenario itself. If I get the liver, ultrasound with Doppler flow, I'll be able to see a clot in the hepatic veins. And if that is the case, it's likely Budd-Chiari. If I get an echo and I see that they have a very blown out dilated right ventricle with a poor systolic activity, then I can say it's probably right heart failure with high central venous pressures. And then lastly, if they have a history of recent hypotension or profound shock with lactic acidosis, multisystem organ dysfunction, and on top of that, a massive elevation in LFTs, I can probably say it's ischemic hepatitis. The next thing is if I have these hepatotropic viruses, so A, E, and even some degree B, if it's massive elevations, I could say that it's probably those acute hepatitis like A and E. And if it's less than 500, I can probably go to the length of saying that it could be hepatitis B and C. Again, hepatitis A and E are going to be more fecal oral transmission. B, C are going to be more bloodborne or sexual transmission. You can see the other types of viruses, such as herpes simplex and CMV, but it's usually more in the immunocompromised state. But again, this would fit in that category of viral hepatitis. In a patient who has a massive enzyme elevation, especially into the thousands, I would always send off an ANA, an anti-smooth muscle antibody, and a soluble IgG. And if that comes back positive, you have a pretty good confidence that they could have autoimmune hepatitis, but they may need a biopsy to confirm, especially if you start them on steroids. The next thing is I'm kind of running into my metabolic disorders. So this is going to be those metabolic diseases. So first thing I would want to know is, do they have non-alcoholic fatty liver disease? Is there obesity? Is there hyperlipidemia? Is there hyperglycemia or diabetes? If that is the case, it's probably non-alcoholic fatty liver disease. And especially look at that ALT-AST ratio. ALT should be greater than AST. Do they have any evidence of emphysema, as well as a reduction in their alpha-1 antitrypsin levels? That could be alpha-1 antitrypsin deficiency. Is their transferrin saturation and ferritin levels high? That tells me that iron is very high in the blood, bound to transferrin, and iron is very high in the cells, bound to ferritin. So these levels are going to be high. And then if I really think that it's a primary cause of hemochromatosis, check the HFE gene, it should be positive. Plus, look for restrictive cardiomyopathy, hyperpigmentation, and even potentially diabetogenic-like states. That would suggest hemochromatosis. Lastly, does the patient have an increase in urinary copper? So much copper in their bloodstream is spilling over into the urine, or a lot of copper that's binding up ceruloplasmin and reducing the free levels of ceruloplasmin. If so, that suggests Wilson's disease, especially if they have Kaiser-Fleischer rings and movement disorders that are present. This is a way of being able to diagnostically approach this in a more simplistic way. All right, my friends, so now the patient has come in, they're presenting jaundiced, right? Usually if you have a patient who comes in and they kind of present a little bit weird and they seem like they maybe have some right upper quadrant abdominal pain, maybe they have some encephalopathy or they have jaundice, you check those LFTs. But I think really more particularly in the setting of jaundice, you definitely want to be checking the LFTs and be thinking, is there cholestasis? So you get the LFTs definitely show that these particular things are elevated in the bloodstream. They have an increase in bilirubin, they have an increase in alkaline phosphatase, and they have an increase in GGT. If these are elevated, it definitely super suggests that this is a cholestasis type of problem. And so then you have to start thinking, okay, what was that differential that Zach said prior? Well, it's either intrahepatic problems with movement of bile flow or production of bile, or it's an obstruction extrahepatic, so outside of the liver, usually involving the common bile duct. So let's say that there is an elevation in these particular molecules. We then have to start kind of dissecting through this and thinking, what would cause intrahepatic cholestasis? And there's two things. One is their hepatocytes are supposed to produce bile, right? That's one of their big jobs. And so it should take and produce bile and put bile from the hepatocytes into the biliary ducts, right? Intrahepatic. But let's say that there's certain types of problems, diseases, that impede this ability to secrete bile. If you can't secrete bile, particularly, a couple things build up in the cells. And one of them is these like bile acids, or just generally lots of bile builds up. As bile builds up, this can cause hepatotoxicity. It increases oxidative stress. And so it will start causing injury to the hepatocytes. And so you may see a little bit of an elevation in the AST, a little bit of elevation in the ALT. That's one thing. But here's the problem. When there's lots of bile, because you're having difficulty being able to do this particular process, what this does is, for some reason, it signals the hepatocyte to start increasing the expression of another molecule that we put out here into the bile system. You know what that molecules are? Alk-Phos and GGT. It's a weird mechanism. We don't have a really great understanding of it, but that's one particular thing that'll happen is you'll increase the expression of alkaline phosphatase and increase the expression of GGT. So it'll kind of really put a lot of stress on these hepatic cells and the biliary cells, and it'll stimulate this increased expression. If we have more Alk-Phos and more GGT being expressed in the biliary tree, these will eventually leak into the bloodstream. And so now some of these molecules will start trickling their way out and trickling their way into the bloodstream. And that will cause the elevation in the Alk-Phos and the GGT. It's a response to inability to excrete bile into the bile system causes a increased expression of Alk-Phos and GGT that causes them to leak into the blood. But how's the bile, particularly the bilirubin component, getting out? Well, when bile is built up, one of those components is bilirubin. And bilirubin is a really important component here. And so I told you that some of these hepatocytes may get injured. And if the hepatocytes may get injured, they may leak specific substances out here into the bloodstream. And one of those particular components is called bilirubin. So we now see how inability to excrete bile can lead to a transient rise in Alk-Phos and GGT and the release of bilirubin from the hepatocytes into the bloodstream. What's causing this particular problem is the question. There's a couple things. One is what we call this cholestasis of pregnancy, actually. We call this cholestasis of pregnancy. This is a huge one. Because in patients who are in like their close to third trimester or going around that, they somehow create this weird effect where usually there's high levels of estrogen. And high levels of estrogen have really been linked for some reason to inhibiting this particular process. So high levels of estrogen are definitely linked to the inability to excrete particular bile components into the bile system. So that's one thing that can definitely do this. That's particularly a problem. Another one is medications, and I bet you can't guess what are some of these medications that have really been linked. There's so many. But one I think that's really, really important to make it easier on you is what's the drugs that really increase estrogen? Oral contraceptives. And so oral contraceptives have been really, really heavily linked to this as well, to increasing the estrogen content and therefore inhibiting these transporters from excreting bile. Those are two big things that really are impeding this process. There's many other medications like anti-epileptics like phenytoin and carbamazepine and a bunch of other stuff, but I don't want you to focus too much on those. Really think about these two. The other things is that there's something that's actually causing either fibrosis or inflammation of the intrahepatic ducts. So what if these intrahepatic ducts are really, really inflamed, or there's fibrosis there, right? That could be potential, or infiltrative diseases there. So there's two particular things that I really want you to think about here. This is a really, really big one. One is what's that disease called? Intrahepatic inflammation of the biliary ducts, only those, PBC. So I really don't want you to forget about this one called PBC, primary biliary cholangitis. The big thing to remember associated with this one is the anti-mitochondrial antibody that is particularly induced and related to this one. It's that autoimmune type of process. There's one more, it could be a bunch of different diseases. I don't want you to get too crazy here, but infiltrative diseases are a big one as well. This could be malignancy, this could be things like sarcoidosis, etc. Don't get too crazy. Really think about this one as a really, really high yield one, and really think about this one, okay? The reason why is these are really great because this gives you a good historical feature on the exam, and this one's probably one of the big ones that has an exam-related antibody that's associated with it. Okay, either way, in these particular scenarios, these are a lot easier because now they're impeding the ability of alkaline phosphatase, GGT, and what's another molecule that's actually present inside the biliary tree if this is working? Bilirubin. I'm going to put Billy. Billy's also going to be here as well. And if you have something that's impeding the flow in the liver, that's going to lead to these guys backing up and going back into the bloodstream. So PBC and infiltrative diseases will impede intrahepatic flow. Cholestasis and medications will impede the secretion of bile. That's the big component there. All right, now we come to the one that's like super easy and very, very, very common. What if I have something that I'm producing bile well, it's flowing through the intrahepatic ducts well, but then when it gets out here and it's running through the extrahepatic ducts, like the common bile, the common hepatic duct, something is obstructing the movement of this flow here. Now we're outside of the liver. What are some potential diseases that really obstruct the flow and prevent this bile from moving forward, causing GGT, alk phos, and Billy to not be able to move forward? They end up backflowing into the blood. So what are some of these things that could actually obstruct the flow? Well, what if there's a stone? I think that'd be a really, really big one here. So what's that called when you have a stone blocking up the common bile duct? It's choledocholithiasis. So if a patient has choledocholithiasis, that's a really big one. Or if they have an infection of the biliary fluid proximal to that, like ascending cholangitis, that could be some big ones. So really be thinking about a patient with a profound right upper quadrant abdominal pain and profound jaundice and increase in these enzymes. Definitely wanted to get about this one. The other one that's really, really important here is going to be primary sclerosing cholangitis. So primary sclerosing cholangitis, this is interesting because it's not a stone. So this one's a stone. So this one's a stone. This one is usually some type of stricture. So it's usually like inflammation, chronic inflammation of the intra and extrahepatic biliary ducts that causes strictures and really impedes flow. This one's really, really interesting. It's kind of difficult to diagnose, but we'll talk about some diagnostic tricks a little bit later. The last one is if it's not a stricture, it's not a stone, it's oftentimes a tumor. And so usually a pancreatic carcinoma should definitely be on the differential here as well, especially in a patient with chronic pain, right? they have hypercoagulability of some sort, and they have jaundice. You definitely want to be thinking about this one. And the concept behind this tumor is it's usually at the head of the pancreas. And you guys got to remember, the bile duct, it actually comes down and then it joins with the main pancreatic duct, usually at the head of the pancreas. So if there's a big tumor that's compressing right there, you're not going to be able to get bile out and into the duodenum. So this will be impaired usually at the most distal level, and that'll cause the bile backflow. The big thing to think about here is that if you think about an extrahepatic cholestasis, for all of these, there's something that's obstructing the flow. And so if you obstruct flow, let's say like right here, I'm just going to use this as an example, a stone. Everything, or it could be in any of these situations, everything proximal to this will start building up pressure. And as you build up pressure, you pump open those kind of like bile ducts a little bit. So with extrahepatic cholestasis, the dead giveaway is when you do exams, like you do what's called right upper quadrant ultrasounds, is you look for what's called ductal dilation. If you see ductal dilation, it usually suggests more of an extrahepatic obstruction of some sort. If you don't see ductal dilation, it likely suggests an intrahepatic source, and you got to go thinking about these particular scenarios. So oftentimes, that's what we're going to talk about in the diagnostic approach next. All right, that's a lot. How do I really put all of this together into a systematic approach? First thing is, again, I'm going to get my LFTs. Is the alkaline phosphatase really high? Is the GGT really high? Okay, cool. It suggests more of a cholestatic process. If I have high bilirubin, that even adds to it. All right, cool. My R value in this particular scenario is probably less than 2. So what am I going to do next? Well, the next thing that I'm going to do is I'm going to go ahead and say, okay, let me get a right upper quadrant ultrasound. You're like, wait, what? Why? The reason why is I want to say if there's an extrahepatic obstruction. If there's a hepatic obstruction or some type of obstruction of the biliary duct outside of the liver, then what happens is all the kind of like part of the bile duct proximal to that obstruction will be super dilated. So I want to know, is there ductal dilation or not? If there is not, then it's probably not extrahepatic obstruction. It's probably intrahepatic cholestasis. So think about a couple things. One is that weird thing I told you, which could be viral hepatitis. Send off all your hepatotropic viruses, and if they come back positive and they have this type of presentation and maybe even have a small elevation in AST and ALT, it's probably a viral hepatitis. The other thing is send off the AMA, the anti-mitochondrial antibodies, because if those come back positive, it could be primary biliary cholangitis. If this is negative and this is negative, then and only then will you make the slight assumption that it could be medication or hormone related. So it could be cholestasis of pregnancy, or it could be drug induced like oral contraceptives, antibiotics, anticonvulsants. However, if you remove these particular triggers or the patient gives birth and then afterwards they do not improve, you should then start thinking about infiltrative diseases. And that's when and only when you would consider a liver biopsy to rule out that they don't have sarcoidosis, amyloidosis, or malignancy. You would not go to this any other way. You get the right upper quadrant ultrasound though, and it shows ductal dilation. Boom, we got a pretty good, at least a consensus that there's an extrahepatic biliary obstruction. And then I start thinking, okay, what could tell me the cause? I could get an MRCP, which is like a magnetic resonance cholangiopancreatography, lights up the entire area of the biliary tree, or an ERCP, but this is pretty invasive, and I wouldn't really do this unless I'm going to actually like do something that I'm treating it for. So MRCP is oftentimes the first line. When I do this, I get a good look at the entire biliary tract, and I can see a stone, which would suggest cholelithiasis. I could see strictures, which would suggest primary sclerosing cholangitis. You see all this beaded like a picture here? This is super characteristic of primary sclerosing cholangitis. And then lastly, I would even be able to see a pancreatic mass, especially on MRCP, or a cholangiocarcinoma, like a biliary mass that's obstructing the biliary tree. And that would suggest a malignant process. And that's how I would go about figuring out the cholestatic injury. All right, my friends, so off to the last one. I think, again, if a patient comes in, they have jaundice, they have some right upper quadrant abdominal pain, I think those are always good reasons to get some LFTs. Again, AST, ALT, predominant elevation, hepatocellular injury. Alk phos, GGT, bilirubin, predominant elevation, cholestasis. What about the patient who presents with some elevated bilirubin, some very elevated bilirubin? And that bilirubin that's elevated the different types of bilirubin that we'll go into a little bit of detail. We already have an understanding of this based on the physiology of bilirubin metabolism, but if unconjugated bilirubin is really elevated, what could that tell us? If mixed bilirubin is elevated, what could that tell us? And then finally, if it's just conjugated bilirubin that's elevated primarily, what could that tell us? Again, these are all part of how we should analyze LFTs. So first scenario, unconjugated bilirubin is really high. So when I look at the bloodstream, I'm going to see a very profound, or to some degree profound, elevation in unconjugated bili. Again, understand that unconjugated bili, if it's elevated, it's again the same terminology per se as indirect bilirubin. All right? So we have to ask ourselves the question, what is the reason that we're having so much unconjugated bilirubin within the bloodstream? And the first one I already kind of gave you a little bit of a start off. One is hemolysis. So hemolysis is a very profound cause of a patient developing particularly elevated levels of unconjugated or indirect bilirubin. So hemolysis, there's so many different types. We'll go through that more in the hematology lectures. But if a patient has hemolysis, sickle cell, or G6PD-H, or autoimmune hemolytic anemia, or whatever it may be, they're busting open these red blood cells. You have to know that red blood cells contain hemoglobin. Hemoglobin contains heme, and heme is the general structure that when it gets broken down makes unconjugated bilirubin. So if we're breaking up more red blood cells than usual, you're going to generate an increase in unconjugated bilirubin. I think one of the big things to understand though is that when patients have hemolysis, there's other things that can make us see that that could be the cause. So if we see an unconjugated bilirubin that's really elevated, what could make us think it's hemolysis? Well, the big thing with hemolysis is you want to look for specific things. Like for example, if I break down red blood cells, what would happen to my red blood cell count? It would start going down. So I would see a decrease in the number of red blood cells. What would happen to the molecule that binds hemoglobin? Well, there's a molecule called haptoglobin. And if it's in the free form, that's good. You'll be able to count that level. But if it's bound to hemoglobin, you won't be able to count that. And so when haptoglobin is bound to hemoglobin, the haptoglobin levels go down. So we'll notice that the haptoglobin levels will start to drop. Now, the other level that really indicates hemolysis is LDH. When these cells are popping open, they release LDH into the bloodstream. And so when LDH is released, it indicates lots of hemolysis. So the more hemolysis, the more elevated the LDH levels. And then lastly, and whenever those red blood cells, they get popped open, we can really see that really well when we look under a peripheral blood smear, and we call those schistocytes. And so look for these. If you see some presence of schistocytes on the peripheral blood smear in combination with the above findings, suggests hemolysis. All right, if no hemolysis findings is present in the setting of unconjugated hyperbilirubinemia, then go to the next step. The next step here is unconjugated bilirubin will bind albumin and will get taken into the liver cells via transporter protein. So now we're gonna have lots of unconjugated, I'm gonna put unconjugated bili here. If there's lots of unconjugated bili, what happens is you have to remember this transporter helps to bring the unconjugated bilirubin into the actual hepatocyte. What if this transporter is in some way inhibited or dysfunctional and it can't bring the unconjugated bilirubin into the hepatocyte? What will happen to the level in the blood? It'll go up. And so there's an actual drug that's been commonly associated with this, and it's called rifampin. So rifampin will cause transport dysfunction. So rifampin will actually work here on this transporter and inhibit it. So think about a patient who is taking tuberculosis drugs as a potential cause. If you find that in the history and the hemolysis labs are negative, you can potentially consider that one. All right, another thing. Unconjugated bilirubin is supposed to get conjugated. And when it gets conjugated via this enzyme here. And this enzyme is called uridine glucuronosal transferase. That's these little blue guys here. What they're supposed to do is they take glucuronate, add it onto the unconjugated bilirubin, and then turn it thus far into conjugated bilirubin. I'm going to put it as conjugated bili. Again, realizing that this is also referred to as indirect bili, and this is also referred to as direct bili. If this enzyme is working, it'll stimulate this step. But what if, in certain patients, they have a decrease in this enzyme. If they have a decrease in this enzyme, this step will be inhibited. Will you be able to take all of this unconjugated bilirubin and turn it into conjugated bilirubin? No. So there'll be a drop, there'll be a decrease in the conjugated bilirubin, and you'll continue to build this puppy up. Think about unconjugated bilirubin is it doesn't have a chain on its length, right? So for example, if unconjugated comes into the cell and you chain it with a glucuronate, it can't leave the cell. But if it's not chained, it can leak right out of the cell into the bloodstream. So what's going to happen to the unconjugated bilirubin levels in the blood? They're going to go up. So you think about three particular causes. 1, hemolysis. 2, rifampin. 3, decreased effectiveness of the UGT. This one we call Gilbert's disease or Gilbert's disease, however you want to pronounce it. But it's a decrease in UGT enzyme function. Oftentimes this can be completely asymptomatic. The big thing is that when a patient develops stress, so some type of physiological stress, let's say, really can decrease the activity. So I'm putting stress, but this can be anything. It's not just the emotional stress, it's more physical stress on the body, sepsis, critical illness, whatever it may be. Oftentimes when these patients get really sick, that enzyme goes down. That enzyme goes down even more, you build up more of the bili. So oftentimes when patients get sick and they have Gilbert's disease, they present with profound jaundice. Okay, next thing here. I think this is helpful because we have the causes of how we're going to work this patient up. The next concept is, how does all of this help us maybe more of the diagnostics for the clinical exam, which is interesting. Conjugated bili has a transporter that leaks it out of the hepatocyte into the bile duct. From the bile duct, it's supposed to leak this puppy out here into the intestines. Here in the intestines, we're going to have that conjugated bili. The conjugate, I'm going to put this as C. bili. Conjugated bilirubin will eventually get metabolized. When it gets metabolized, there's a bunch of bacteria that's naturally present inside of our GI flora, part of our intestinal flora. They're going to metabolize the conjugated bilirubin into what we call urobilinogen. And then urobilinogen will further get broken down into what's called stercobilin. And stercobilin is what gives the pigmentation to our stools. So this process kind of catalyzed by enzymes, and this one's just naturally this process here. Some of this urobilinogen not only goes into stercobilin, but some of it gets reabsorbed and gets taken back via what's called the portal vein. So I'm just going to write this down so you guys know this vein. This is called the portal vein. And then from here, it generally kind of comes back into the actual bloodstream and then to the liver. But some of this will get into the bloodstream. So it'll come back, go here to the bloodstream, but I'm just going to represent it kind of coming off here eventually. What happens is this urobilinogen, when it goes to the actual kidneys, it gives some degree of color to the urine. Now in this scenario, there's less conjugated bilirubin. There's still going to be some urobilinogen. It's just going to be a little bit less. This urobilinogen will then go to the kidneys and give a color to the kidneys. It gives it that yellowish discoloration, if you will. And if urobilinogen is somewhat normalish, then the urine should be appropriately yellow. It won't be dark. So I'm just going to put here, just really important here, no dark urine. And there's one other thing. There's not going to be dark urine. Stercobilin, there's still going to be a decent amount of stercobilin being produced. If there's less stercobilin, really, really important here, your poop will become pale. You're not going to have pale stools. So if you don't have pale stools and you don't have dark urine, in this patient, think about unconjugated or mixed hyperbilirubinemia. Then check, do they have hemolysis? They don't. Think about rifampin. Are they taking it? No. Think about Gilbert's disease in the scenario of stress. Then again, consider no dark urine, no pale stools. Okay, it's not any kind of conjugated hyperbilirubinemia. It's likely unconjugated. This is the big thing for this one. All right. We go to the next scenario. We have another patient that comes to us. Similar kind of process here. All right, so let's go through this in the same way. This patient has, again, how do we do this part here? When you break down, naturally this happens normally. When you break down red blood cells, you produce a molecule called unconjugated bili. Now, you're not producing a excessive amount than you usually do in this scenario because there's no hemolysis. Unconjugated bili is still getting taken into the liver cells because there's no increase, there's no kind of like transport dysfunction here. When it gets taken into the liver cells, you're going to have a normal amount of unconjugated bili. You're going to have a normal intact UGT enzyme. If this enzyme is intact and it is properly functioning, then it will lead to the stimulation of this getting converted into what's called conjugated bilirubin. Here's the difference. Conjugated bili will then also be excreted out into the biliary duct. Now you're trying to kind of come up with an interesting concept here. This patient has mixed hyperbilirubinemia. Well, how? Okay. Well, the process here is, what if I take this liver cell and it's got normal red blood cell breakdown, normal transport function, normal UGT, normal excretion of bili. But what I do is I just bust open this cell. And in this when I bust open this cell, I'm going to release a normal amount of conjugated bili and a normal amount of unconjugated bili. But they're going to leak into the bloodstream. When these leak out into your bloodstream, what you'll start seeing is you'll start seeing over time more and more and more unconjugated bili and conjugated bili in the bloodstream than you should. In the cell, it's normal, but out in the bloodstream, you'll notice that this will start causing an increase in the unconjugated and an increase in the conjugated. I'm going to kind of abbreviate these again. Unconjugated, indirect bili, conjugated, direct bili. The increase in both of these is from hepatocellular injury. In other words, I've damaged these hepatocytes. So if I have a patient who has hepatocellular injury, I'm going to write that down here. Hepatocellular injury, this will then stimulate an increase in what's called total bilirubin, an increase in the total bilirubin. What are causes of hepatocellular injury? We already talked about this. This should be fresh in your brain. Drug-induced, Tylenol, alcohol, autoimmune hepatitis. Could be vascular causes such as ischemic hepatitis, Budd-Chiari syndrome, right heart failure. It could also be to metabolic diseases, Wilson's disease, hemochromatosis, non-alcoholic fatty liver disease, alpha-1 antitrypsin deficiency. These are big things to be thinking about. Patient has cirrhosis, acute liver failure. All of these scenarios are hepatocellular injury, and they'll cause a rise in both of these. The other concept is that if you have a patient with hepatocellular injury, what other things will be elevated? Oh, shoot, Zach, if that's happening here, then I'll also notice that I'll have an increase in the things that are also present in these cells, such as AST and ALT. So in a patient who has an increase in their AST and their ALT with a combination of an increase in total bilirubin mixed, that really suggests hepatocellular injury, and then think of the cause. All right, cool. All right, so now, conjugated bilirubin in this scenario is normally excreted. So it's normally released into the biliary ducts. When the conjugated bilirubin is released into the biliary ducts normally, it'll then move out here and get into the small intestine. When it's into the small intestine, what do we say happens? Again, you have conjugated bili will get converted into what's called urobilinogen. All right, so you're still going to have these guys. And then what happens is we know that urobilinogen is going to be formed by breaking down conjugated bilirubin from bacteria. This can then get recycled. If it is recycled, some of this urobilinogen will then go to the kidneys. When it's taken to the kidneys, it'll then help us to make urine appear more yellow, not dark. So you're not going to really have dark urine here, and you're still having urobilinogen eventually being converted into stercobilin. And so therefore, if you're still making stercobilin here, you're not going to have these pale stools as well. So no pale stools and no dark urine. That is also helpful. All right. Now in some scenarios, some of the textbooks say that the stools may be like slightly pale and the urine may be it's not very helpful. I think the best scenario to think about whenever you have dark urine or pale stools is this last scenario that we will talk about. All right, cool. So a patient comes in, They present with right upper quadrant pain, maybe some jaundice. You get some LFTs, you see elevation in these, and you see elevation in these, you think about a hepatocellular injury. Patient comes in with jaundice, no increase in AST, no increase in ALT, and it's primarily unconjugated. You think about hemolysis, rifampin, and Gilbert's. Last scenario, you have a patient come in with right upper quadrant abdominal pain and some jaundice. You get their levels, and their LFT show that they have a profoundly elevated conjugated bilirubin. That's really important. So we're going to go through this pathway. It's going to be literally ingrained into your brain. So you have your red blood cells. They're normally broken down, not excessively more than usual, but they're broken down. They give way to what's called unconjugated bili. Whenever you make this unconjugated bili, you're not making it more than usual. You're not making an excessive amount from this hemolysis. This is still going to be taken up by the liver normally. It's then going to be metabolized by these normally functioning UGT enzymes. These are intact. So you're going to have this occurring, and this occurring. You're still going to make conjugated bili. But here's the difference, my friends. The conjugated bili is made, but maybe there's a problem with being able to excrete it. There's transport dysfunction. So this part right here is inhibited. If that's inhibited, I'm not going to be able to get conjugated bilirubin into these biliary ducts. Eventually, it'll build up in the cell, and eventually some of these will start leaking into the bloodstream. So that's one thing. So one thing I'm going to put out over here is that this conjugated bili will start rising slowly into the bloodstream. Okay? That's going to start rising slowly in the bloodstream. What's a disease, or at least two diseases, that cause transport of the conjugated bilirubin out of the actual hepatocyte into the bile duct? Let's write these down. One would be, we call this very interesting. So this is going to be a transport dysfunction. These are super rare, like crazy, right? They love to ask these though sometimes on your exams. One is called Dubin-Johnson syndrome. And the other one is called what's called Rotor syndrome. So you have two types. One is called Dubin-Johnson syndrome, and the other one is called Rotor syndrome. And these, the whole purpose here is that this is causing this particular process to occur. You're not excreting conjugated bilirubin. Okay, that's a problem because if I don't excrete the conjugated bilirubin, it builds up in the cells. If it builds up in the cells, eventually it will leak into the bloodstream. All right, that's one cause. What's another one? All right, what if inside the liver there is a problem where I'm having also difficulty excreting bile? So you know bile is also supposed to be excreted here. Well, there's a disease, we talked about this before in cholestasis, it's called intrahepatic cholestasis. Do you guys remember that? So it's kind of like a process where you're supposed to be, let's use this kind of like transporter, like I say right here I have like a transporter of some sort, and it's supposed to help me to push some of this bile contents out here. Or the liver, so let's say here's a bile duct, I'll use like a dotted line, let's use this. Here's a dotted line, and this dotted line indicates everything above is intrahepatic. Everything below this dotted line is extrahepatic. So if this is intrahepatic and there's some type of dysfunction with either excretion or there's some kind of like inflammation or strictures or infiltrative disease, it's going to impede the bile flow into the extrahepatic ducts. What are these called? It's intrahepatic cholestasis. We talked about these. You guys remember? Just a couple of them, the most important ones. Please don't go crazy. Just the most important ones. One was PBC, right? The AMA related. And the other one was cholestasis of pregnancy. And then we said that it could also be related to oral contraceptives. Last one is, what if I have something that's extrahepatic? So I'm supposed to be allowing flow to move this way, eventually at the pancreatic duct, and then I cause obstruction right at this level. It's a stone, it's a stricture, it's a tumor. That's going to be extrahepatic cholestasis. So if a patient has extra hepatic cholestasis, this is going to be affecting the common biliary duct generally. This is going to be, again, what were those 3 most common causes I told you guys about? It's a stone, such as choledocholithiasis, or it's going to be a stricture, or it's a tumor. So this would be choledocholithiasis. It'll be primary sclerosing cholangitis, or a pancreatic tumor. Where? Usually at the head of the pancreas. So this is the concept here. If I'm having inability to excrete it, transport dysfunction, inability to excrete, and inability to move it forward because of an intrahepatic obstruction, intrahepatic cholestasis, or an obstruction from a stone, tumor, or stricture extrahepatic of the common bile duct, that's going to impede the movement. So I'm just basically not moving conjugated bilirubin from the level of the hepatocyte all the way down to the biliary system. In this particular scenario, what's some of the other molecules, though, that are in the biliary system that'll help us, that'll also leak out into the bloodstream? You guys remember? Please tell me you remember. These molecules were alkaline phosphatase and GGT. So if a patient has a profound elevated GGT, a profound elevated alkaline phosphatase in the setting of intrahepatic cholestasis and extrahepatic cholestasis, that also really helps the diagnosis. Usually this is the only one that will not have the alkaline phosphatase and the GGT. I'll put like a little symbol here to remember that. No increase in alk phos and GGT. So again, no change in alk phos and GGT. These ones, they will have increases in alk phos and GGT. Now, keep understanding this topic here. Don't excrete it, can't move it along. What's else going to happen here? Am I going to get any conjugated bilirubin out here into the actual intestines? No. There's going to be a really, really low number of conjugated bili. Another concept is, if there's less conjugated bili, can I make what's called urobilinogen? No, because I don't have enough of this guy. So this process is also going to be impeded. That means there's less urobilinogen to travel via the hepatocytes and eventually get into the bloodstream and eventually go to the kidneys. So now from here, there's going to be a decrease in urobilinogen. If there is a decrease in the urobilinogen, that's a problematic feature because it's supposed to give some of that kind of more of the yellowish coloration to the urine. Here's the other concept. There's a lot of conjugated bili. Lots of conjugated bilirubin, when actually released into the urine, if you got lots and lots of conjugated bili, it makes the urine much more darker appearing. So now if you have an increase in conjugated bili and a decrease in urobilinogen, guess what's going to happen to their urine? They will have a very dark appearing urine. This is the one that you will see this in. You won't see this really dark urine in the other ones. Same concept. Less urobilinogen. What does urobilinogen eventually get metabolized into in the poop? Stercobilin. Are you going to make as much stercobilin if you don't have urobilinogen? No. What's going to happen to the stools? You're not going to have that kind of pigmentation to the stools. And so you will then form and stimulate the formation of pale stools. So less urobilinogen means less stercobilin, less pigmentation to the actual stool, and you'll end up with pale stools. So if a patient comes in and they get their LFTs and it shows increases in conjugated bilirubin with no change in alk phos and GGT, transport dysfunction. Increase in alk phos, increase in GGT, increase in conjugated bilirubin with dark and pale stools, think about intrahepatic and extrahepatic cholestasis. Okay, now that we've gone through all of this, let's cover the diagnostic approach. Let's put a lot of this to practice because it is a lot. First thing, there's an increase in total bilirubin. So in other words, there's an increase in unconjugated and conjugated bilirubin. The next thing that you'd want to do is fractionate out your bilirubin and figure out which one is elevated. Is it conjugated or unconjugated? So let's say that you do that, and you find that your indirect bilirubin or your unconjugated bilirubin is elevated. What does that make you think about? Okay, that was hemolysis, that was rifampin, or it could be UGT deficiency like Crigler-Najjar or Gilbert syndrome. So let me go through this. First thing, if I have this, is I should check, what did Zach say? Oh, hemolysis labs. If the hemolysis labs are negative, meaning that I'm going to have a normal hemoglobin, I'll have a normal LDH, a normal haptoglobin, and no like abnormal reticulocytes, then I'm going to say it's probably Gilbert or Crigler-Najjar. It also could be another potential process such as rifampin, because again, that had nothing to do with hemolysis. If the hemolysis labs are positive, there's a drop in hemoglobin, a drop in hematocrit, there's decreased haptoglobin, there's increased LDH and increased reticulocytes, it's probably hemolytic anemia. And I'd have to further work that up, which we'll talk about in our anemia section in hematology. If there is an increase in unconjugated and conjugated bilirubin, this is a mixed hyperbilirubinemia. So this is where it starts getting a little bit more interesting because it's probably a hepatocellular injury. So if there's an increase in AST and ALT, it's definitely hepatocellular. And I'm going to work these patients up the same way I would work up any other hepatocellular injury. The next one is if the conjugated bilirubin is the only one that's significantly elevated, then it's probably a conjugated hyperbilirubinemia. So then I got to start thinking, okay, is that like maybe that transporter dysfunction? Is it intrahepatic cholestasis, or is it a biliary obstruction that's outside? It's in the common bile duct. Okay. Well, first thing Zach also said is that alk phos, if it's elevated, and if GGT is elevated, it's definitely cholestatic, intrahepatic or extrahepatic obstruction. Wait, how did Zach say that I determined the difference between intrahepatic cholestasis and extrahepatic? Wasn't it the right upper quadrant ultrasound? And if that was present and I showed me that there was ductal dilation, that has to be extrahepatic obstruction. Things like a stone, a stricture, or a mass. If it was negative, that's probably intrahepatic cholestasis. And then I should check the viral serology to see if it's viral hepatitis. I should check an AMA to see if it's PBC. And if all of those are negative, think about cholestasis of pregnancy, drugs, and if they don't improve, get a biopsy to rule out infiltrative diseases. Right. But if the AST, the ALT, but more importantly, the alkaline phosphatase is normal and it's just an increase in the conjugated bilirubin, I should start thinking about those weird transporter disorders, such as Dubin-Johnson syndrome or Rotor syndrome. And that's how we talk about hyperbilirubinemia. And my friends, that covers LFTs. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.